Well, good morning, everyone. I want to welcome all of you to the Bipartisan Policy Center. My name is Anand Parekh. I'm the Chief Medical Advisor here. Welcome to today's event entitled Reinventing Rural Healthcare, a case study of 7 upper Midwest states. For those of you who are new to BPC, our mission is to actively seek to combine the best ideas from both parties to promote health, security, and opportunity for all Americans. We drive principled and politically viable policy solutions through the power of analysis, negotiation, and advocacy. Today's event is being streamed live online, and a recording will be available later today. We invite you to interact with us on Twitter about today's event using hashtag BPCLive and the handle BPC_bipartisan. We'll also be taking questions today after both of our panel discussions. If you're watching online and have a question for any of our participants, you can tweet at us and we'll try to get to those during the question and answer. We're gathered here today to focus on the 46 million Americans, 15% of the US population, who live in rural areas. Areas that comprise 72% of the nation's land, 15% of the American population residing in 72% of the nation's land. Rural Americans are older, have comparatively more disease burden, and lower per capita income. Shortages of healthcare workers and geographic challenges, including terrain, harsh winters, and distance to emergency services, make it all the more difficult for people living in rural areas to address these challenges. But as Daryl Birch, who you'll hear from shortly, a CEO of a critical access hospital in North Dakota, once said, quote, "Just because we live in rural areas in this country, we shouldn't have to settle for anything less than the best healthcare services," end quote. It's in this spirit that the Bipartisan Policy Center, in partnership with the Providence Center for Outcomes Research and Evidence, launched an effort in 2017 to better understand the needs, opportunities, and innovative efforts of those working on the ground in rural communities to improve patient care. During this project, BPC focused on 7 states in the upper Midwest region of the United States: Iowa, Minnesota, North Dakota, South Dakota, Nebraska, Wyoming, and Montana. In this effort, we are very thankful for the support of the Leona M. and Harry B. Helmsley Charitable Trust. Today, BPC is issuing a report which identifies 4 specific themes for policymakers that require attention. BPC believes these learnings also apply to rural areas across the United States. The 4 themes are: number 1, healthcare services need to be right-sized to fit community needs and not vice versa, where services define communities. Number 2, funding mechanisms and payment models should reflect the unique challenges that rural areas face. Number 3, local pipelines for young people need to be supported to build a 21st century workforce focused on primary care. And number 4, telemedicine can be a great tool not only for patients, but also for provider recruitment and retention. Remaining barriers and challenges need to be addressed. Today we'll explore these themes in greater depth with 2 panels, the second of which will consist of healthcare experts from the upper Midwest who have traveled here to be with us today. At this time, I'd like to introduce our first panel. We're very pleased and honored this morning to host Senator Heidi Heitkamp and Senator Mike Rounds. Senator Heitkamp has represented the state of North Dakota in the U.S. Senate since 2013. She is currently the co-chair of the Senate Rural Health Caucus and has introduced a number of bills during her tenure to improve access to affordable care in rural communities. A lawyer, she was formerly Attorney General and Tax Commissioner in North Dakota, and also a successful businesswoman in the private energy sector as well. Senator Rounds has represented the state of South Dakota in the U.S. Senate since 2015. He previously served as the 31st governor of South Dakota from 2003 to 2011, and before that served in the South Dakota State Senate and also built a successful insurance and real estate business in the private sector. We welcome back the Senator to BPC, where he previously served on BPC's Governor's Council and co-led BPC's health project with former Senate Majority Leaders Tom Daschle, Bill Frist, and former Governor Ted Strickland. Moderating the discussion with the 2 senators is BPC President and founder Jason Grumet. And so at this time, please welcome the senators and Jason Grumet to the stage to get us started. Thank you.
Good morning, everyone. A lot of this discussion is about the challenges of isolation and the difficulty in getting to essential services. And I'm talking about the inch of snow in Washington. My children's school were closed today, and I think when it talks about the hardiness of the people to my left, Senator Rounds is indicating that school never closed. Senator Heitkamp told me that the kids go outside as long as it's at least 10 degrees below zero. Our little flowers are not let out the door if it's under 43. So I say this because it does provide a little bit of insight into the different kind of ethos between this kind of Amtrak corridor and the people who live in these frontier areas. And I think it speaks to the fact that the solutions that we have identified are going to be very different, and in some ways potentially much more efficient than what we have designed for healthcare in much of the rest of the country. So let me start off with a couple of general thoughts, questions. Senator Heitkamp, you are the co-chair of the Rural Health Caucus. You may have noticed things are a tad partisan these days in Washington. Do you see rural health care as an issue that has the potential to provide a kind of more united front? And what are the issues that might drive that process?
I think it's interesting because when you talk about rural health care, it's virtually impossible to have a real meaningful discussion without talking about the challenges of rural America. Higher poverty rates, more isolation, less transportation, aging population, and now we have challenges in the ag economy with low commodity prices, and in our states a growing concern about drought, which is huge. And so I don't think that we can really talk about healthcare unless we talk about meeting all the challenges of rural America. On top of that, when you look at private employment in my state, basically the largest private employer in a state like North Dakota is in healthcare. And so not only do we have the challenges of rural healthcare, we know how critically important providing that healthcare is to the economy of our state. And you'll see that all across the region on the states that you've identified. I will tell you that rural versus urban issues aren't as much partisan issues as they are jumping up and down and saying, look at us, look at us. And I think the introduction was so well done because when you're looking at 15% of the population, which is in 70% of the land mass of this country, you know that you have a hard time getting attention. And that's why I always tell people, I get up every morning and my first thought is, what am I going to do for rural America? Not rural health care, but we can't have rural America without rural health care. I think one of the frustrations that I have with how we deal with policy issues in Washington, D.C. is we revisit the same issues over and over again. And we saw that with the doc fix. We see that with 430. We see that with physician supervision. We see that with 72 hours. I mean, I could go through the whole list. And you say, if we fixed all of those things and gave you permanency, that would be a good thing. Let's admit that. That'd be a good thing. But it won't solve the problem of dealing with rural health care. And that's why the work of this commission and committee is so critical. That's why we want to thank the Helmsley Foundation for focusing on rural health care, because it's hard to get foundations to really focus on places like ours, like North Dakota. But I think we need to do what I call look up. And Daryl will also talk about the work that we've been doing with the Hospital Association with healthcare providers. I started right away with an advisory committee on healthcare. And my challenge wasn't just tell me what you need right now. My challenge was look up, what do you guys, how are you going to do your job of providing healthcare into the future in 5 years, in 10 years, in 20 years. And it's going to have to look different than what it looks right now. But I think you've identified the right challenges, but I think we need to be driving a proactive strategy in rural health care that doesn't just fall back on the easy, 1, 2, 3, 4 that I just gave you, but actually talks about systemic change and fighting for a different way of delivering and paying for healthcare services in rural America.
So, Senator Rounds, Sir.
Well, first of all, let me just say thanks for the opportunity to come back in and to visit with the Bipartisan Policy Council. I can tell you that right after I was governor, I was a part of the organization up here, and I thought that you brought a lot of credibility with regard to the discussion of these particular types of issues. I also wanted to today I wanted to say thanks to the Helmsley Trust as well, because what they have done for us in rural America is critical. They have already made a true and dramatic change in the healthcare in the upper Midwest. Walter Panzer is here today, and it's great to see Walter. I've worked with Walter since the time that I was governor in South Dakota. And the Helmsley Trust has made a huge difference in rural America healthcare already. Numbers count, and I think you're going to be able to disclose some very, very good numbers today. And I also just want to mention that what you really talk about here when we talk about the federal versus the rural and what the feds can do to assist or to make it easier for healthcare to be delivered in the rural area, there are a number of areas that I think we should be talking about. Let's just begin with stability. And by that I mean, we're going to talk today, we're going to have the announcement today of another continuing resolution. The continuing resolution that's being proposed is to go from January 17th today, or the 19th, until February 16th. And my question is so where does that get us? It doesn't provide any stability for rural health carriers, doesn't provide any stability for the hospitals, doesn't provide any stability whatsoever for folks that look at contracts with the federal government. And yet here we are just kicking the can down the road another couple of days. That's because we haven't found the necessary gumption to actually come together and make some agreements among ourselves, Republican and Democrat, conservative and liberal points of view. We've got to live in this country, and yet we find ourselves struggling just to get by day to day. It's a terrible example to the rest of the world of what should be stability in our great country, and it's time we face that. So let me just start. First of all, we can offer stability, and that's critical here at this point for those healthcare providers. Second of all, I really do think we have to address some of the challenges yet left over from the Affordable Care Act. In rural areas, when I was governor, we had, now get this, we had 17 companies offering group insurance coverages in South Dakota. We had 13 companies offering individual individual coverages in South Dakota. Today we've got 2. And part of the reason for that is when you make it more difficult for companies to actually do business and to compete with one another, they leave, they go elsewhere. And the capital that's behind them leaves as well. Today, when you take a look at the Affordable Care Act and what has been delivered, while the goals were admirable with regard to providing the best possible coverages and care that are out there, you're not finding it necessarily delivered to some of those people who right now can't afford to buy it. I think we've got to find a way through it. I think Senator Alexander and Senator Murray were providing a very reasonable approach to stabilizing the health insurance market, which would really help in rural parts of our country where in some cases there's maybe only one carrier available in an entire state. I think in North Dakota, I think we've got 3. In South Dakota, we've got 2. But I think we have to address it. We can't walk away from it. We can't simply say, well, we can't get anything done, so we're not going to do anything. I think we've got to continue to work and find some common ground with regard to a long-term and stable healthcare solution. The answers are out there, but it's going to take some agreement among people with differing points of view. And we start by actually passing a budget and appropriations for more than 1 month at a time.
I'm guessing there's quite a bit of agreement with that basic premise. Senator Heitkamp, you called on the senators for Medicaid and Medicare CMS to form a rural health council, I think in part informed by the challenges Senator Rounds was indicating about Congress's ability to move forwards. Do you see the opportunity to collaborate with the executive branch to advance some of these issues absent legislation?
I think one of the frustrations that we always have in rural America is the one size fits all. Whether, as Senator Rounds and I are engaged in a banking reform bill that is directly related to this problem of Dodd-Frank being too big to fail, becoming too small to succeed. And it has greatly contracted mortgage lending in rural America because of the inability of affordability of compliance burdens. So I think that's a great example where we can work together to identify those things that don't work in rural communities. that where reimbursements need to be redesigned in rural communities. One of the great challenges that you've identified that is that if you talk to anyone in rural America, it's transportation. How do you get people where they need to go, or how do you get personnel to where the people are to basically provide a quality healthcare product? And so what I would say is that we need CMS to be flexible. We need them to understand that we're not trying to deliver lower quality care. And I appreciate so much in the introduction Daryl's comment, that we're committed to providing the highest quality of care, but we need the flexibilities to do that. And one size does not fit all. And so as a result, we've pushed the last administration very hard to have a unique look at rural health care. I think this administration is continuing that work. We're grateful for that. And we think some good things can come out of it, but they won't if we simply hunker down in rural health care and say, fix these 3 things or 4 things and our problems go away. Our problems are not going to go away until we get systemic reform. And, Senator Rounds talked about the Affordable Care Act. Well, I'd be curious with the healthcare providers who are here, what percentage of the healthcare that you provide is Medicaid or Medicare? So that private insurance market, albeit critically important, is not the only thing that we need to look at. And the federal government is critical, and federal reforms are critical to delivery of rural health care. As we said, it's an elderly population, and they're going to have higher costs, and they want to stay where their church is, they want to stay where their community is, but yet if we don't provide rural health care, we take these great rural citizens and we basically force them to relocate to places that their comfort level isn't there. And so I guess my point would be, yes, we need to fix the private market. I think we're both on the Alexander Murray bill. We think that will stabilize for a 2-year period while we actually have the right conversations about health care. But we also need the federal government to understand that one size does not fit all, that we need to give these great healthcare professionals, providers, the flexibility that they need, and trust that they really do care about their patients. They really do care about the quality of health care that they're delivering. And they really are amazing people with great capacity to innovate.
So I have 17 more questions. I would like to ask one of them and then give you all an opportunity to ask a couple. So think about what you might want to inquire. We have some fleet-footed mic runners. My final question is to ask you both to talk a little bit about broadband and telemedicine. The president, led by our good friend Secretary Perdue, has just come out with a rural prosperity study which really focused on this question of broadband, and yet again has said we should use, I think it was all viable tools to accelerate the deployment and adoption of high-speed broadband connectivity. Senator Heitkamp, this is something I've heard you talk about as well. Why can't we do this?
We can.
Yeah.
We absolutely can. And in fact, Chairman Pai just yesterday announced his proposal for $500 million and additional resources being made available in rural areas for high-speed internet, broadband. What we're really talking about is if you can watch your favorite college team on TV or on a computer, you ought to be able to also provide appropriate connections in emergency situations between professionals in institutions with huge capabilities to make contact with people in rural areas. This is a doable deal. And in fact, let's bring this back in again. The Helmsley Trust, Walter can probably share with you later on today what they've done with e-pharmacy, e-telemedicine, and in South Dakota, we're actually doing that. A number of our major providers, our healthcare providers, are providing doctors on the spot in rural areas, but through telemedicine. This is a doable program. This is not something in the future. This is being done today. But it's got to be expanded, and the capabilities and competencies have to be expanded. Chairman Pai is right. If you put $500 million into expanding broadband into your rural areas, that means not only can you provide better healthcare opportunities and communication, but you also build business opportunities as well. I remember when I was governor coming in and lobbying the FCC because what they wanted to do was to have 2 standards, one for upload and download in rural areas and a different one in urban areas. And the urban areas were getting a fair shake. The rural areas, though, for some reason, they didn't need as much upload and download. And my point was I disagree. If you really want businesses to succeed in rural areas, you've got to give them the ability to communicate at the same speed as if they were in an urban area. Get those broadband capabilities up. There's something else as well. Let's start talking about fifth generation. Let's talk fifth gen, because when we talk fifth gen broadband, you're also talking about enhanced security. Security is going to be one of the most critical issues when it comes to internet connections in the future. It's here today, but the next steps have got to recognize not just high speed, you've also got to have the security built in so that you can actually communicate back and forth and the bad guys can't get in and cause problems. So as we talk about broadband communications and how they deal with rural health, remember that you've got to have the security built into it as well so people feel the confidence to utilize those systems as well.
Senator Heitkamp, I know you're on a very tight schedule, so maybe a couple words and we can get a question or two.
Great. The couple things. I have what I call the Netflix test. There isn't any millennial who's going to live in any community where they can't stream Netflix. So if you don't have it, then we're failing, right? So you know, I know that entertainment is the interest in quality of life kind of drives this, but behind that is all that business opportunity, all that innovation that Mike was just talking about. What I will tell you that I don't think it's talked enough about is that how connected rural communities are is very disparate in this country. You know, everybody assumes that there's no part of rural America that's connected. I can show you my mother-in-law's farm in rural Stutzman County has better access than some parts of Fargo. So we can't take a broad brushstroke and just cover this. North Dakota has done a great job in rural telecom. Where we haven't is tribal. And so we can't leave the tribal communities behind because access to these services is so critical. But I will tell you that we need a major strategy. I'm going to give a shout out to a colleague, Shelley Capito, who has really taken this on. She formed, and a lot of us assisted her in forming the Rural Broadband Caucus. She's been driving this initiative along with another number of rural community senators, and we're gonna make this a top priority of infrastructure reform. And so we're in the 1940s, 30s, and 40s. We all talked about getting the last mile of electricity. Now we have to do that in broadband and in communications.
So we have time for a couple of questions. Right up front. And please let us know who you are.
Lou Gagliano, independent healthcare consultant. I want to go to the issue of some of the rules that CMS through the MACRA program has initiated and go to the issue of measurements of quality standards, which I think have driven down and concentrated on the fact that if you concentrate on quality, you drive down costs, you benefit everybody. Those rules first applied to hospitals. They're now going to be applying to patients. Insurance companies are using them to direct value-based contracting to those institutions that give better care. In principle, these are good principles. The question is, can they equally apply to rural health care? And if not, how do we get them to be morphed so that they are fair and do drive the kind of principles that we'd all like to see? Thank you.
I'll just give a quick answer to that. This is exactly the issue that drove our demand that CMS really began to focus on rural issues, because we could see the angst coming from providers saying, we don't know what these standards are going to look like. There's a law of unintended consequences. When they're focusing on things that we don't think drive quality, how do we have input? Because the one thing that no one talks enough about, in my opinion, is the fact that what CMS does will always be mirrored in the private insurance market. And so, you know, it's not just CMS and the federal government, it pretty much drives healthcare decision making. And so that's the role, what you're talking about, how do we prevent that from happening? That's the role of this special attention in CMS to rural issues.
I mean, just to lay it out in a way that I think frustrates a lot of our rural communities. If you've got a physician's assistant that's providing care in a community, and you have a local hospital where you have a doctor, but you also have a doctor who is overseeing PAs. At what point and how many times does that doctor and how many of those PAs can that doctor oversee before you risk losing coverages for the benefits of having a PA? We maybe can't afford to have that doctor in every small community, but in many of those communities, that PA provides a valuable service. So does CMS in their rulemaking recognize that a PA may very well be the best that we're going to be able to provide? And as long as there is appropriate communications with a supervising physician, should you now start to cut out the funding because, well, the doctor doesn't have face-to-face rather than a broadband connection? And what about the monitoring? What about when it comes to providing those services in a nursing home setting? Are we now going to be talking about, in some cases where you have a nursing home, you may not have access to all of the professionals because you simply can't afford them, and they're in demand in the larger communities. But if you've got a face-to-face by internet, is there an allowance for it under CMS rules? And there's one other thing. You should never take any one of these rules that's been put in place as being perfect to begin with. Tax law is not perfect. Insurance laws are not perfect. Reimbursement rate laws are not perfect. And none of them should ever be put in stone. If you really want to talk about opioids and the addiction challenges you've got out there, take a look at the guidelines for determining whether or not pain is being appropriately managed and what role CMS has in causing part of that problem. If you walk in and a hospital is asking, or in the surveys that are being asked, how was your pain managed? And you're going to get dinged if somebody says, well, I did have some pain, versus someone who says, nah, they took care of me just fine, man. I didn't feel nothing for days. Well, that may sound really good until you start talking about the addiction rates that go up because of that. And so in some cases, this is a case of where you should constantly be looking back over and finding out whether or not the reimbursement rates, the analysis, the surveys, and so forth are appropriate, and should they be modified based upon the outcomes.
Yeah. Just to play devil's advocate for a minute, if that's quality care in rural communities, why isn't it quality care in urban communities? Maybe that's the problem, is that the rule doesn't make sense in any context, that we're overworking or overpaying for quality health care. Can we do it at a lower level? My husband's a family physician. If you asked him, he would tell you that the days of family physicians are probably numbered, that it's not a specialty that a lot of people would go into because they are being replaced by physicians' assistants and nurse practitioners. And so what's our level of expectation as a population on quality of care? Is it always the doctor with the MD is going to be the highest quality and everybody's entitled to that? And so I think we have to be careful that we don't marginalize rural health care by saying it's okay for that rural patient, but not okay for that urban patient.
Let me just hit real quick on one thing, though. If you really wanted to make an impact on rural health in the upper Midwest, take a look at Indian Health Service, or the lack thereof. I mean, if you really want to talk about improving the lot of lives for real Americans who live in rural areas, and you really wanted to see a critical impact and increase in the quality, then take a look at IHS. Because if you want to talk about a healthcare failure, it is IHS. Upper Midwest region, North Dakota, South Dakota, Nebraska, and Iowa. Take a look at why is it that Native Americans in that area have a lifespan which is 10 years less than the average American? Why is it that the rate of diabetes is the highest in the nation? Why is it that tuberculosis rates are the highest in the nation? It's because IHS has absolutely failed. They don't communicate with the tribes that are there. They do not provide the appropriate levels of services. Heck, they can't even tell you how they allocate the resources that are provided to them on a regular basis, except, well, that's the way we did it last year. They haven't had a qualitative analysis of healthcare in IHS since 2008. Now you tell me how you provide true healthcare without having a qualitative analysis that's being performed. That's your federal government at work, or in this particular case, not at work and not being fixed.
So, Senator, that's something we heard quite a bit on our tour. I am quite certain that the senators would rather spend several hours here based on what is waiting them back up the street. But I have promised their staff that we'd actually let them do the people's work. And if I could just indicate how appreciative we are, not of just you being here today, but of the work that you do. I think the example that you set is one of the reasons why we are still bullish on the long arc of American democracy. And I want to thank you for spending time with us today.
Yeah. Thank you. Thank you. Thank you. All right.
Great. I want to go ahead and thank once again Senator Rounds and Senator Heitkamp, and thank you, Jason, for that terrific first panel. At this point, I'd like to introduce our second panel to the stage. If our panelists could please join me here on stage. You have their bios, but our four panelists today are Daryl Birch. Daryl is CEO of Sakakawea Medical Center and the Cole County Community Health Center in North Dakota. We have Dr. Heidi Duncan, who is the Physician Director of Health Policy in the Billings Clinic in Montana. Mr. John Dunn, who is Director of Physician Services at Nebraska Methodist Health System. And Dr. Keith Mueller, who's the Interim Dean of the University of Iowa College of Public Health and Director of RUPRI Center for Rural Health Policy Analysis in Iowa. Thank you all for being here. So maybe we can start by, again, the audience has your bios, but a little bit of color from the four of you on what your day, every day is like. What's the environment that you all are working in? What's sort of the role in the healthcare sector that you have? And I think that'll be some good background for the audience as we then proceed. Keith, do you want to get us started?
Well, as you know from the bio, I've been involved with the Rural Policy Research Institute for more than 25 years now, running the health portfolio that includes the center that Anand mentioned in the introduction, also the RUPRI Health Panel, and many of my comments today will come out of RUPRI Health Panel documents. We've been spending a lot of time over the last 5 years trying to help develop policy ideas around how we achieve a high-performing rural healthcare delivery system across the spectrum, if you will, of a number of pillars of what that system looks like. Most recently, a sort of companion piece to the one we're talking about today that we just produced called Taking Stock, where we look at where are we now across the policy arena. So that's where a lot of my attention goes. In the research center realm, we look at areas like accountable care organizations, Medicare Advantage, health insurance marketplaces. But really what I'm here to talk about today is the sort of policy drivers toward achieving those goals for a high-performing system.
Great. Heidi?
Yes, so I grew up in rural Montana and was lucky enough to come back to Montana to practice family medicine when I finished residency. I continue to practice 3 days a week, and then I'm the Physician Director of Health Policy, and I've been doing that work for Billings Clinic for the last 3.5 years, so it's been a very steep learning curve. Billings, for those of you who don't know, is the largest city in Montana at about 140,000 people. We are a regional hub for healthcare. Billings Clinic is a fully integrated physician hospital organization, and we have 11 management agreements with critical access hospitals. So part of our strategy has been to be very supportive of our regional hospitals in our rural communities. Also, Billings Clinic has been very supportive of graduate medical education and has participated with our neighboring hospital in Billings in a family medicine residency program in Billings for the last 20+ years. And then a few years ago, recognizing the need for continuing to grow internal or primary care physicians, started an internal medicine residency. Also, another huge need in rural areas, as you all know, is mental health care services. And so we're actively looking now at partnering with the University of Washington to get a psychiatry residency training track. So we've realized workforce is a very important part of rural health care services and have been committed to that work as well.
Great.
My name is John Dunn. I'm from rural Iowa. Originally have been a resident in Omaha working for a Methodist health system for several years, as well as in the interim have worked for some private subspecialty physician services. A lot of the work that I do is basically establishing outreach services that includes traveling specialists of cardiologists, pulmonologists, vascular surgeons, medical oncologists to the rural communities. Most of that is physical on-site, either on once a month, maybe twice a month. If there is a real frequency, it could possibly be up to once a week. We also work quite a bit with the CME, the continuing medical education that is specific to the primary care physician in the rural environment, because their needs are certainly different because of sometimes the lack of resources they have and the need to identify disease processes in their office. And so we work with that on a regular basis. And more recently, we have worked with the community hospitals, the critical access hospitals that we sponsor in Southwest Iowa. We've extended our value-based shared savings agreement from the Methodist PHO, Physician Hospital Organization, the contracts. The most recent is with Wellmark, which is really basically Blue Cross of Iowa, and we extended that shared savings plan to 3 of the communities in Southwest Iowa that had upside and downside financial potential, and have dealt with some of the challenges of that. So it's basically whatever hat there is available I wear.
That fits.
We're not going to go into the rest.
Good
We'll
morning.
get back to the challenges, Daryl.
My name is Daryl Birch, and I'm the CEO of Sakakawea Medical Center, which is a critical access hospital located in Hazen, North Dakota. But I also have the unique privilege of being the CEO of a federally qualified health center, Coal Country Community Health Center. And through that partnership, we're able to take advantage of programmatic benefits of the health center program, the hospital program, for the benefit of our communities. My role is to make sure that I lead our team to identify those issues that are rural and that are rural in our communities that we need to address as healthcare providers. And in doing so, then, to provide our staff with the resources that they need to get the job done. But then also, again, to repeat myself, to utilize the programmatic benefits collaboratively of the health center and the hospital program to work together for those needs.
Great. So BPC's report, as you know, and was discussed, had 4 critical areas of learning: right-sizing healthcare services to fit community needs, creating rural funding mechanisms and payment models that address the unique challenges faced in rural America, building support and supporting an appropriate workforce that focuses on primary care, and 4th, expanding telemedicine. Which of these 4, as you sort of went through the report, sort of resonated with you? And what are the areas that resonated with you? Are there things that surprised you? Are there other points in the report that really struck you? Keith,
Okay.
Sure.
Well, what leapt out at me initially was, from all of the discussions of the roundtables that were held, a level of not just willingness, but desire to move forward, to change the way healthcare is delivered and financed in rural communities, but to do that in each community, not to try to do it with a uniform policy for all. So the willingness, the desire to get engaged, and then the frustration, which we heard a little bit about in the first panel this morning, that we're constantly trying to make sure that we are at least secure so you have a baseline from which you can make the change. So another part that came through in this report was something that in jargon we sometimes call a runway or a glide path to enable the local community leadership that includes the healthcare organization to move toward something different, but while they're making that move, to make sure that the delivery of services remains secure. So the kinds of policies that the senators are fighting for here over the next couple of weeks, sometimes called Medicare extenders, for example, on the payment side, are critical for that need to maintain that base, but as well, policies that facilitate, not mandate the specific change, but facilitate communities making the changes. And I'll close with an example of that, and that's the use of community health needs assessments now by a lot of our small critical access hospitals and others around the country. While that may have come out as a mandate by law, they've been able to take advantage of that to really better understand what are the community needs for health in our community, which is leading to a lot of discussions about how do we get there? How do we maybe reconfigure services? How do we work in a collaborative way with other organizations locally and networking regionally? So those are some of the key takeaways that this report brought to my mind.
Yeah, the CHNAs are great tools, these community health needs assessments. Yeah. Heidi?
It all really resonated. I finally had a chance to read it cover to cover on the plane yesterday, and I think my poor seatmate must have wondered what I was doing, because I kept going, yes, yes. But I also really appreciated how this report, while it talks about different areas, there's that sense that really this all has to kind of come together for us to be successful in rural America. And even just how do we start tackling some of the frustrating policies that are already in place, rules that have been written from the CMS level? How do we start peeling back on some of that? And then how do we start to build and really look at what other people are doing? How do we right size? How do we have these conversations between our different communities about what's working and what's not working? But and just one example of just the frustrating slowness of what it can take to undo an unintended consequence of a rule. There was something in the Affordable Care Act that was interpreted by CMS to limit payment for residents rotating in rural hospitals. It was something that was completely unintended, but it is going to take a legislative fix now. We have language sitting in a bill. The bill has only 4 sponsors. It's sitting in Senate Finance, and it's been there for at least a year. Again, there's all these little policies out there, a number of different examples I'm sure you could all come up with. How can we package some of that and just get some of this nonsense taken care of so we can then move forward and do some of the other real work of how do we change the policies and fix how we deliver care.
Great. John?
I guess the one that is most appropriate and timely for me is the financing part of it. My experience with the shared savings, the value-based plans, although that the responsibilities usually lie with the primary care physician, in the rural environment, that's not where the expense is. The expense is at the tertiary centers when you're referring those people on for whether it's cardiac or pulmonary or oncology, and that is where the true cost is, and yet they have no control over that. And I guess the transparency of the cost, because the different entities, the different facilities, and on government plans the cost is the same primarily, but on commercial plans they can vary greatly on the agreements, and there's not a transparency where even the primary care physician knows if I send to cardiologist who works in facility A versus the cardiologist who works in facility B, that there is a $30,000 difference in the cardiac care. And so it's hard to manage the cost of care and be responsible for that when you really don't know, especially at the primary care level. And so there's all the others apply totally, but from my experience, that is the most relevant here on keeping the lights on. So.
Thank you. Daryl?
And certainly all 4 themes in the paper are very prudent and touch upon a lot of key issues that there are in rural America. But certainly when you sort the wheat from the chaff, as we say in the rural areas, it's all about community and having essential primary care services available in our rural communities, whether it's a critical access hospital, whether it's a rural health clinic, whether it's a federally qualified health center. Access to primary care services in our rural communities is essential. And it's easy for us to go like this and point that the federal government is not taking care of things. The state government is not doing it. But when we do this, there's three that are pointing back at us. And what can we do as communities to maximize the resources that we do have available, or the services that we can provide by pushing the envelope so that we can do our mission of providing those local healthcare services. As Keith Mueller has said often, form follows finance in how we deliver healthcare. We're operating in silos of care that we're restricted to. But those silos can be bent and broke to some degree, and we can do a better job of maximizing different programmatic benefits for our community.
In the audience today, we have staff members from Congress, we have members from the executive branch as well, many federal agencies. If there's sort of one thing that you would want policymakers to better understand about rural healthcare that you don't see a current appreciation for, what is it that folks need to know that they might not know yet?
I would start with the strength of rural healthcare and what a tremendous asset it is to have a system that is primary care based, focused on the needs of the local population. A lot of debate is occurring in environments like this and in the boardrooms of large payers about how they move the payment system around, and they're very concerned about the total cost of care and total healthcare expenditures. You know, a solid system with a very good primary care foundation and good emergency services focused on the population of the people being served in its community is, I think, the fundamental piece to addressing a lot of those more global concerns. But we have a tendency to think about the global concern and reduce that all the way down to the level of individual events. So we think about the price of a particular encounter rather than thinking again about a healthcare delivery system with that primary care base. So I think that's the sort of underappreciated strength of what's out there in rural. We need to strengthen it even further. But that would be where I'd start.
Great.
I agree with that, and I think the point of one size doesn't fit all is another really important take-home message. What is rural in Pennsylvania is a very different thing than what is rural in Montana or Wyoming. The geography, the space between communities really forces us to be creative, and we can't say what works in one place necessarily works for another place. So I think when we're designing policies, payment systems, whatever we're talking about in this arena for healthcare organizations, it really has to give those communities the flexibility to say this is what works for us, and allow some flexibility in those policies.
And I think that distinction is very important. Frontier health is not necessarily the same as rural health, which is not necessarily the same as sort of suburban, semi-rural, or other. And thank you for making that distinction, John.
I guess it'd be incentivizing the rural, especially critical access hospitals and the metro-based tertiary hospitals to work closer together. Whether you're a part of that system or whether you're independent. I mean, the most obvious is post-acute care. When they're discharged from a tertiary institution, whether they've had open heart surgery or some other major, and they need to go to a skilled nursing facility, why is it that I think a significant portion go to metro-based skilled nursing facilities instead of back to the rural facility, the critical access hospital that has swing bed capability, yes, and it offers continuity because that's where the primary care physician is who referred the patient to begin with. And that is, although it's practiced by some, it's not a front burner item for a lot of the facilities because there is a little bit higher cost associated with a skilled nursing facility based in a critical access hospital. And so we need to incentivize the cooperation and incentivize care to be provided, especially post-acute care at the critical access level. So.
Certainly agree with the comments about one size does not fit all from a regulatory perspective and from a service delivery perspective. And the country is shifting from a volume-based delivery system to more of a value-based system. And I think having those in Congress and our state legislators understand the need to invest in prevention and wellness will help reduce costs. It won't reduce costs today, but it will be next week, next month, next year. So investing dollars in helping those individuals with multiple chronic conditions to prevent acute onset of disease. Let's help those that are fairly healthy get healthier. And if dollars were put towards those kinds of activities in the rural communities, I think it would go a long way for our population to improve their health, to improve how we deliver health care as providers, and then ultimately reduce cost for the payers, whether it's Medicare, Medicaid, those entitlement programs, or commercial insurance.
Daryl, the report talks about sort of right-sizing healthcare services, but then also aligning incentives and priorities of healthcare entities in a region. You have a very unique setup, and perhaps other places have this, but we'd like to learn more. But you are CEO of both a federally qualified health center and a critical access hospital. Mm-hmm. Talk about how co-leading both those entities together has been helpful to meeting the community needs. Is that a model that's replicated elsewhere? If you can talk a little bit about that, and then if you don't mind, if I can add one more question. I believe that you all also use telemedicine, and perhaps are one of Avera Healthcare's sort of e-care and e-emergency care clients. Talk about how that service has helped provider retention as well as provider recruitment by having that service. So 2 questions there for you.
Certainly. Well, I'll talk about telemedicine first then. We do have in our emergency room e-emergency that initially was made available to us through grants from the Helmsley Charitable Trust. And I can't say enough about what a difference that has made and how important that has been for our staff and our providers, but also for the patients that we end up serving. Because we have ER providers that are family medicine physicians or physician assistants or nurse practitioners who can take care of a lion's share of issues that come to us in our emergency room. But then there are those unique and difficult and challenging situations when people present to the ER in a trauma situation, cardiac arrest. So using e-emergency then to have a board-certified emergency physician available to help guide and counsel our providers and our nursing staff has been just critical. And critical to many, many communities across the upper Midwest. So it's very appreciated. It's an important service that ends up happening. And that's just one of the telemedicine services that we're taking advantage of. And we also have e-pharmacy and other services as well. But to have the opportunity to talk about our unique structure with being the CEO of a critical access hospital and a community health center. At times there are very contentious and competitive relationships in small communities between any provider types, but especially between federally qualified health centers and critical access hospitals where resources are limited for workforce, for providers, and the number of patients that we see are fairly limited too. So what we've been able to do in this structure that we end up having is we're able to take advantage of both the hospital and the health center programmatic benefits and take advantage of those for providing healthcare services to our community in the most cost-effective and best way that we possibly can. We've done so to ensure that that's in place by having the shared CEO, but we also have integrated governance in place where we have governance that's shared between the 2 organizations to make sure that our mission and our focus is on our community, and that's what drives us then to have that community focus. Once we started collaborating, we did the community health needs assessment, and we didn't just do it because it was a requirement. We had to do it because of that too, follow the regulations. But we really used that tool and that assessment then, and we brought in various partners, whether it was the hospital, the health center, public health, the local nursing home, local EMS. We brought everybody together to partner, and we assessed our community needs from all of those perspectives. We developed then a strategic plan and developed a community health improvement plan. And instead of doing that plan and then setting it on the shelf, we actually use that month in and month out to do a couple of different things. We do population health initiatives where we work with our community to identify those areas that we should be working on. A healthy Halloween bash where you offer fruits and vegetables instead of candy. And in our area to have 300 kids come to that is awesome. But we also have a group then that works on care coordination and transitions of care, when you have individuals represented from all these different service delivery types, you can really talk about and make a difference in those services that you're providing and being as effective as you can.
Great. John, I want to ask you about the value-based transformation, and Daryl has referred to this slow, in some cases, transformation occurring in America, how we pay healthcare providers based on moving away from volume to value, and Keith alluded to this as well. There are a lot of alternative payment models being tested right now. ACOs, bundled payments, accountable health communities, global budget models. Based on your sort of rural communities, and you're working with clinicians every day, which of these models do you think has the greatest promise for moving us away from volume based on your experience?
Well, I have limited exposure to it, but it would seem to me the first stage seems to be the shared savings plans.
Yeah.
It's the least contentious, and it's the least issues with governance and splitting that dollar. You know, if you do a bundled payment plan, the game is on. And it's with every specialist and every provider and every facility associated with that bundled payment, and everybody fighting over that one piece. So I think the best, from a shared savings plan, you're starting to become intentional and aware of cost and quality. And that is what we all need, no matter what our goal is, you know, whether it's healthcare costs or weight loss, we need to be intentional about the decisions we're making. And it is through the educational process of all the aspects associated with those cost centers. First we need, you know, in the educational approach that I've been using, basically you need to educate the primary care providers on their coding. You know, are you coding for every disease aspect that you're dealing with? Because every one of those disease aspects basically assigns a risk score to that. Every risk score correlates with a per member per month basically budget. And that is what you're dealing with from a starting point on actually potentially having a shared savings. And so everybody needs to kind of understand the importance of that. And so the education starts with coding education. It starts with understanding just the basic premise of how this game is played. And I think that has I think it's the best educational tool, and that's how I've approached it with most of the providers. Guys, this is not going to change your lifestyle, but it is something you need to learn. You need to learn how this works and how to be intentional about all the decisions you make and about who you're referring to and what are the costs of care in the facility and the provider that you are sending to, as well as their quality outcomes. So it takes the whole picture into place. So I have very limited exposure, but that would be my approach.
Heidi and Keith, thoughts on value-based transformation and alternative payment models?
Yeah, my comments would echo John's. It's hard to, for example, volume is such a challenge in rural areas, and I think we have to design our programs so that rural areas with small volumes can participate in these value-based propositions, because a lot of people want to. But even at Billings Clinic, which is our largest regional provider, we tried to participate in the hip and knee bundle, and our volumes were low enough that you get a few outliers and your shared savings is gone. So we pulled out. So I think we really we need to continue to be creative. How can we do programs like these in areas with low volumes? And how is it changing regulations so that more people can partner together? I don't know what the answer is, but we need to look at that, because volume is a big driver of a lot of the inability to participate.
And I would agree with a couple of points that were just made. The shared savings platform at the present time, I think, is the one that is most amenable to the kinds of adjustments that need to be made in a rural environment. So we're working right now on a paper on this, we're seeing a tremendous spread of that model across rural America, much more rapidly and comprehensively than we thought. But right now it isn't recognized, please. It's a shared savings model where you can share in the savings, but you're not at risk if expenditures go the other direction. So it's not yet really a full risk-bearing model. The other piece of this is, what I sort of said earlier, that we want to move toward a payment model that is based really on the total cost of care, not trying to squeeze additional savings or even the value-based model like a bundled payment for individual encounters or even small bundles. You run into the volume issue and you're not really going to bend the cost curve that much. We really need to be looking at the total package of expenditure. So models like global budgets begin to make a little bit more sense. They're at higher risk, and so we're, the fact that we're experimenting now in Pennsylvania and Maryland, but not a lot beyond that yet, that's an indication, yes, it's higher risk and you have to be ready to do that. And I'll close, and you would expect this from a dean of a college of public health. I think we need to be focused around population health and what it takes to maintain a healthy population, because that will drive down those total costs. It'll drive them down both in people not needing to come in to begin with, and it will drive them down for people with chronic conditions being more appropriately cared for in environments that don't draw them in to the high expense clinical environments that we have.
Heidi, I want to just shift and talk about GME, graduate medical education policy and financing. Keith has always talked about, and I think the panel would agree, that primary care is the backbone of rural healthcare, is the strength of rural healthcare. Certainly we need non-physician providers, NPs, PAs, to practice at the top of their license. Scope of practice laws are very important in all of your states. We need community health workers. We need a range of health professionals. But for primary care physicians, what changes, are there changes that you think that are required in GME policy to increase the number of primary care providers, particularly in rural America?
Thank you. I could go on at length about GME policy, but I'll try to focus a little bit more. I think program is really the concept that's emphasized in this paper of looking at the pipeline is very important. So how do we get communities to start to identify early those kids who would go into medicine or some of the other ancillary services and come back to their communities to practice? I think it's not really something that necessarily centered in policy or in payment right now, but I think that's a very important concept that we need to remember. And then I think probably the statistic that impresses me the most is really where people do residency or where they're most likely to practice, not medical school residency. So getting physicians exposed in residency to rural medicine is going to definitely help workforce in rural areas. You have to be comfortable. I trained in family medicine at University of Washington, and I did some rotations in some of the rural communities, but I wouldn't have been ready right out of residency to go without a lot of support into one of the smaller communities and staff the ER or do C-sections or those sorts of things that are required in a lot of these rural communities. So really supporting the programs that send residents out into these rural communities and give them exposure to those practices are, I think, a huge win in helping the workforce solution in rural areas. So there's a lot of different policies that are out there that are either promoting it or in the way, and we just need to continue to keep looking at those, look where how the money flows and be creative about some financing, not let our GME caps limit some of those programs.
Great. So lots of challenges, lots of opportunities as well, but perhaps before we get to audience question and answer, one additional round of questions so we leave on a positive note here. Can you share an example of a story that you see as signs of progress in rural healthcare, where you are, where you can report that there's progress on the ground, and there are some signs that if we continue moving in the right direction with public and private sector support, that we can continue to improve the quality of care in rural America. Can each of you share a story or an example? Daryl, do you want to start?
Certainly. typically in rural areas such as ours, it's difficult and challenging to participate in an accountable care organization. But we found ourselves participating in one as well, and we're really able to see the difference that we're making in how we coordinate care and how we coordinate the transitions of care that our patients need to go through between home and community and nursing home and the hospital. But one specific example, I think this speaks louder than any other thing that we've talked about, is the fact that we had a patient who was utilizing the emergency room and local EMS 2 times per week. Different issues and challenges that this individual had would call EMS and utilize volunteer EMS services to take that patient to the hospital. The hospital then would discharge, and there would be a follow-up, and et cetera, but week in and week out, this was what was happening. Through our population health and care coordination meetings that our staff have, and God bless them for the work they do, all these different provider types come together and they talk about specific patients and how can we improve the lives of those that we're serving. And in this particular case, they worked with this patient. The community care coordinator went into the person's home. There's routine calls that are scheduled with this individual. There are routine clinic visits that have scheduled. And now most recently in the last quarter, there have been 2 ER visits in the last quarter. So it makes a difference, one patient at a time, as we provide these services and we coordinate that care. So we've improved the life of this particular individual. We've improved how we're delivering care to this individual and can learn from that experience to others. And then in the long run as well, we're saving money, and that's the triple aim that CMS always heads towards. So that example to me, it just really resonated with me.
Thank you, and that's to John's point that this is all these models are creating more awareness and more accountability, and people are finally thinking about these things.
I guess the communities I work with are really under strong leadership. And what I have noticed is too many times people in the tertiary centers think that they're offering and it's a one-way street and we've got so much to offer you. And the truth of the matter is the innovation in many times I'm finding is coming from the rural environment. And it can be done in a half-an-hour meeting rather than over a series of months through multiple committees. And so it is, I've seen it at one of our local communities, Red Oak, Iowa, Montgomery County Memorial Hospital. They're doing home monitoring of chronic care patients with COPD, congestive heart failure, diabetes. Those have been high risk and recently dismissed, and they have set up their own parameters on, they're not being reimbursed for that, and that is one of the policy things that I think needs to be changed, because if we're going to truly control costs, that is how we do it, through managing chronic care. And the other thing that they have done, and so we as Methodist Health System, I said, we're keeping an eye on you. We're going to see how successful you are with it, and it's been really strong. And the other is their development of a mobile clinic where they go around to those communities that do not have storefront clinics, but they have them on a regularly scheduled basis. Every Tuesday they're in this community, every Tuesday, every Wednesday they're in this community. And it's not totally unique, but it is unique in our region. And it serves a great population, and it is staffed by a nurse practitioner with many of the counter lab testing that you can do in any clinic environment. So it's very strong, and these people all have transportation issues. If they're going to go any place, they usually have to have a child, have them take them someplace. So it's a great access issue. So
Great.
One example that comes to mind for me is along the technology front is taking advantage of something called Project Echo. It's a program that started at the University of New Mexico around hepatitis C work, and it's expanded around the country. We're using it in Billings for mental health services, and the concept is you have a kind of a hub and spoke where there's a physician and a panel of care providers at the hub, and then people from the different communities can call in. In this case, we have rural communities. We've piloted a project with the Fort Peck Indian Reservation, and they can present cases to the panel and discuss among the group. So it's kind of the wisdom of the crowd too. Anybody can participate, but weekly, an hour-long sessions. People can call in and discuss with a specialist or provider individual patient cases. So it gives support to the rural communities and those rural providers, makes them feel more connected, and is a win for everybody.
That's great.
And I'll fall back on a couple of public health examples of communities where we've done case study work in Iowa, where the local critical access hospital took a lead role in bringing people together in the community across different types of groups. The local United Way, as an example, the local public health department, all toward trying to create, because we were doing this under this auspices, a culture of health in their community. So the underlying health indicators would be affected by that kind of collaboration across healthcare, social services, local civic leadership. But to sustain that, you needed an entity for whom that's of high priority. And again, coming out of those community health needs assessments, that turns out to be the local hospital and the leadership that comes out of the hospital, and then use of some of the hospital's physical plant. So in one of the communities, they converted some unused space. Going back to the right-sizing piece that's in the paper, they converted some of that unused space into a wellness center environment because there wasn't another place in that community where that could easily be done. So it goes back to what was said earlier about the gain for that and some of the triple aim kinds of concepts may be long-term, but we're seeing the immediate gain in what's happening in, again, the culture of health in those communities.
Great. Well, why don't we move to audience question and answer? I think we could probably keep talking for a while. We touched a little bit on telemedicine, but we might want to come back to that. But there are roaming microphones on either side, so just please raise your hand and we'll get a microphone to you.
Lou Gagliano, an observation and a question, and perhaps you can comment on this. The community-based concept of delivering care, I think, is very important, whether you call it community-based care or ACO. There's some jaundice at the national level about whether ACO works or not. The challenge for your group is I think you have a wonderful basis to prove that it works. And I would encourage you, because the belief is the economics of this doesn't work. The economics of it will work. We're just too impatient to realize it. But you have the measurement because you're dealing with population numbers that you can prove that the outcome in cohort groups don't wind up in epic events at hospitalization if you have them appropriately connected to the care network. So my challenge to you, for example, is use what you have to make policy people in the United States realize that most of the patients a lot of the patients we're dealing with are Medicare patients in these communities. And who pays for those costs? Well, I think it's Washington.
I'll just add to Lou, and Keith, correct me if I'm wrong, I think to that point, if you look at the advanced payment track of the accountable care organizations, in fact, rural ACOs, rural Medicare ACOs do better than other ACOs because they have precisely what you're saying, sort of that primary care backbone organization.
And it raises the point, I made the point earlier about ACOs being primarily the one-sided risk model it's called right now, but in some of the demonstrations that CMS, CMMI have put forward, there's been an impressive array of rural participants in some of the two-sided risk models, like the Pioneer when it was out, and now the advanced ACO model.
Yep. Other questions? Yes.
Gary Filerman, I'm on the board of ACCME, the Accrediting Council on Continuing Medical Education. I'm interested in what you would say to the CME superstructure relative to its effectiveness in serving the rural communities.
You. Tag, you're it.
I think it's time for a critical look at how we finance graduate medical education in this country. And I think that because there are places where it is a win financially for hospitals to train residents. And for those of us in the rural parts of the country who are supporting residencies, it's not a financial windfall. In fact, it costs us money to do this work. So, I don't know how you start to chip away at some of these long-standing policies and practices, but I would ask that that people start looking a little bit more at, as those GME dollars flow, how can we make certain that the money do follow the residents to rural programs? How can we incentivize to put some of the more GME spending without necessarily getting into a battle of taking it away from somebody else? But how can we change structures so that we can make it at least not a huge financial loss for some of the community hospitals to train residents, whether you're a rural critical access hospital accepting residents from a branch program, or whether you're a little bit of a bigger system like ours, who is trying to train residents more locally so that they will go and stay in those areas to practice. How do we at least not make that a loss for people? I don't know, that's not a great answer to your question, but it may come down to having to take away a little bit from people who are already getting money. I don't know if that's the right answer, but restructuring things and having more community health centers and FQACs and these centers that also our family medicine residency is based out of a community health center. But the two hospitals support that residency. How do we make those partnerships more viable so we can get residents out to these places and train them?
And just to clarify, the question was focused on GME or CME?
CME.
CME.
Oh, CME. Oh, I'm sorry.
That was a great GME answer. Heidi's going to give me a CME answer.
CME. Telemedicine. Bring CME. Make it easier for people to get their continuing education in their communities if you're a primary care person in a rural area, or have coverage so that they can go to CME meetings if they need to. They have that professional interaction. I don't know if that answers your question either, but
Great.
Can I add to that? I think in content in CME, the healthcare professionals are going to need some training in what it's like to work in the newer environments and the changed financial arrangements, and we really need leadership to come out of the clinical side. And I know that we've been asked in our college to help provide some of that kind of training now on a continuous medical education basis. That's what they're clamoring for.
I think there was a question. Yeah, right here.
Thank you. Hi, Gabby Galvin with U.S. News and World Report. Daryl, I want to take it back to the Community Health Center and Hospital Partnership. As you're aware, the funding gap for the community health centers has had a lot of effects for other organizations around the country. I'm wondering whether you've seen some of those adverse effects, hiring freezes, laying off staff, having to stop programs like telemedicine there, and whether the role of the hospital has changed at all in response, whether it's been able to fill any kind of gap.
So as of this particular point in time, we haven't needed to change any services or reduce staff in any form. Our funding cycle works out to our benefit in this regard, but certainly we hope that Congress will come together and fund not only the Community Health Center program, but there are many programs out there that are important to rural that we certainly hope get some funding on a longer term basis.
Great. Yes.
Good morning. My name is Rachel Tetlow with the American College of Obstetricians and Gynecologists. We've been increasingly alarmed by reports of closures of maternity wards in rural hospitals. So I'm hoping that you can talk a little bit about that, and in particular, if you see that as a separate issue or a symptom of some of these larger issues that have been discussed this morning. Thanks.
Great question.
I can probably speak to that a bit. It's in Montana, we've certainly seen that. Just in the years I've been practicing at Billings Clinic, 2 of our critical access hospitals that are only about 30 or 40 miles from Billings gave up doing, the family physicians there gave up doing obstetrical practice. And a lot of that had to do with not having anesthesia coverage, actually. I think people sometimes think that it's malpractice insurance, and those are definitely problems, but oftentimes it's that coverage and support. So it's a real thing. I don't know that once a hospital is gone there, if they can ever go back, because it's difficult to do, even if you have physicians who are comfortable doing it, who are trained to do it. Our solution was we partnered with our partners in those communities. They did the maternity care up to about 32 weeks and then transferred their patients into us. Some of us, the family physicians who were still doing OB, and then some to our obstetrics department. And we were able to at least provide this service to that community. They could stay in their community for a while and send people back. But I really don't know how going forward you change that. Again, I think it's looking at individual communities having to right-size things. What is the problem in that particular community with providing the obstetrical services, and how do you support that if it's important to keep it there? I suspect it's a different answer for everybody.
And if I can just make a comment to add to that. Whereas, as was described here, where we used to deliver babies years ago before the time that I got there, but there comes a point in time where you can't afford the resources for 24/7 ER coverage or the physician coverage to be able to provide services. But we do both pre and postnatal care with our patients and work with the OBGYNs that come out of our tertiary facilities in Bismarck, so that they come monthly then and do the follow-up visits both pre and post. The other thing is, if you only deliver a half dozen or so babies a month, is your staff still proficient and skilled at doing that as you want it to be? So it's making those decisions that it's not only right for the facility, but ultimately right for the patient as well.
We have time probably for one more question, final question. Yes, please.
Tate Hewer with the American Academy of PAs. Both of the senators at the beginning of the discussion talked about how increasingly primary care services are shifting to PAs and to NPs. And there's been some discussion of graduate medical education today. A few rural health centers in the West Coast are starting to have joint PA and NP residency or postgraduate programs to have these providers more accustomed to providing care in those settings when they start. I'm just wondering if there are any thoughts about if there might be more widespread application of programs like those and if they may be useful.
I hadn't been aware that there were those joint programs developing. Yeah, I think certainly we have a lot of examples in Montana, and I'm sure all the other states do as well, where you really do have the NP or the PA as that sole provider in these rural communities, but connected to a physician. Montana does have independent practice for nurse practitioners, but again, I think we really that connectedness is important, whether you're a MD, a PA, or an NP, and how I think the conversation needs to be more around how do we best support those people practicing in those communities to make sure that they have what they need from the telemedicine, broadband access in the ER or in their community clinic. So, but that's intriguing. I've not heard of that model. Thank you.
Well, great. I want to first start by thanking this terrific panel. Thank you for traveling all the way here and sharing your personal experiences and your thoughts. I think it is so meaningful to hear from all of you directly. You know, we had a prep call last week and talking about the weather. The high in the locations the panels were at was 0 degrees. So thank you for coming to DC, where 30 degrees and dusting of snow and all our schools were closed. So you get to experience sort of what we go through in the Beltway. But thank you for being here. I want to thank the audience for your terrific questions. Today, I want to thank our partners, our funders. I want to thank the BPC staff as well. The Bipartisan Policy Center will continue to share the findings of this report and raise visibility about all of these important issues in the weeks to come. I think one major takeaway is this notion that rural health care should not be considered a niche issue. In fact, it is a national issue affecting Americans in all 50 states, and it needs to be prioritized. And I think we look forward to working with all of you, stakeholders and others and policymakers, to ensure that some of the solutions to these challenges can continue to move forward. So thank you for your time and your interest, and we'll talk to you soon. Thank you, everybody.